This conference will now be recorded.
Good morning, students. Audible? One of you answer, am I audible or not? Students audible?
Yes, ma'am.
Fine. So this is the first class. Topic for today is anemia in pregnancy. So you have a basic idea about anemia, right? Have you heard of this word anemia or not? What is anemia? Is this first time you are listening? Anemia. Fine, I will carry on. So anemia is nothing but decrease in the oxygen binding capacity, means her hemoglobin is less. So the pathology can be with the genesis of hemoglobin, or its early destruction of RBC, or acute bleeding. So there are various forms of etiology for this anemia. So acute blood loss is an emergency, like our obstetric blood loss, antepartum hemorrhage or postpartum hemorrhage, or an abruptio placenta. All these are emergencies, like in case of ectopic pregnancy when she is bleeding internally, or post-abortion hemorrhage. So these are all acute bleeding. And like in case of non-pregnancy, what are all the symptoms and signs of this anemia? The patient will be having easy fatigability, weakness. If she is still severe anemic, cardiac overload, complications, pedal edema. So, and she will develop this koilonychia. All these will seen in non-pregnancy. So, what are all those effects in addition to all these non-pregnancy in pregnancy? So effect on the mother, effect on the baby. How can we prevent it? Prophylaxis. How can we treat if she is already anemic? So how can we prevent? So in an antenatal woman, that too in Indian scenario, when she enters into second trimester, she will become anemic compared to non-pregnancy. In pregnancy, because of the increased demands of baby, placenta, mother, and one more thing called physiological anemia of pregnancy. So starting from 6-7 weeks of gestation itself, she will develop hemodilution. So the plasma, there are a lot of physiological changes in pregnancy. The plasma volume will be increased. RBC also will be increased, but the increase in RBC is far less compared to the increase in plasma volume. So there will be a state of anemia. You call it as physiological anemia of pregnancy or dilutional anemia. So to combat all this, when the patient nausea, vomiting and all subsided when she enters into second trimester, that way in your history taking also, second trimester we ask for whether she is on iron and calcium supplementation. Okay. So to prevent she becoming anemic, we give prophylactically anemia, and we continue throughout the pregnancy and also after delivery also for 3 months to replenish the stores and all. And also in lactation also there is increased demand for this hemoglobin. See, by definition, this is qualitative or quantitative reduction of HB or circulating RBCs or both, resulting in decreased oxygen carrying capacity. As per WHO, less than 11 gram per deciliter, you take it as anemia. According to CDC guidelines, first and third trimester of pregnancy, that is less than 11 gram per deciliter. In second trimester, you take a cutoff of 10.5 gram per deciliter. So degrees of anemia also we have a grading according to CDC. 7 to 10.9 gram per deciliter you take it as moderate anemia. This is in pregnancy. 4 to 6.9 gram per deciliter you take it as severe. If it is less than 4, it is very severe anemia. Also in ICMR classification, mild is 10.1 to 10.9 gram per deciliter. Moderate is 7.1 to 10 gram per deciliter. Severe is 4 to 7, 4.1 to 7, and very severe again it is less than or equal to 4 gram per deciliter. So this is the basic. When the patient comes to you, you suspect anemia, she is looking pale or she is still with symptoms and signs of anemia. So then you have to grade her based on her hemoglobin, how severe anemic she is. And one more thing we discussed, this physiological anemia of pregnancy. The plasma volume increases by 40 to 45%, and this maximum increase occurs at the gestational age of 32 weeks. So that is the period where maximum hemodilution is there. And if she is a cardiac case or a case of severe anemia, this 32 to 34 weeks is also period where she is likely going to failure, cardiac failure. And RBC increases by 15 to 20% only. So plasma volume is increasing almost double or more. Thereby disproportionate increasing in this results in physiological anemia of pregnancy. So to tell it is physiological anemia of pregnancy, her HB should be around 10 gram per deciliter and RBC should be 3.2 liter per cubic millimeter. Packet cell volume, that is hematocrit, should be 30%. And the peripheral smear should show normal morphology. Like in case if we have iron deficiency anemia or thalassemia, it will be a picture of microcytic hyperchromic. If it is folate or B12 deficiency, it will show macrocytosis. But here to call it as physiological anemia, the peripheral smear should show normal picture and the HB should be around 10 and PCV 30. Usually this PCV will be 3 times that of HB, usually. And RBC 3.2 liter per cubic millimeter. So this is the picture of physiological anemia of pregnancy. And what are the causes of anemia? The most common, that developing countries like India, that to pregnancy, that to women, nutritional anemia, starting from the childhood, adolescence, teenage and pregnancy. They will be in a state of nutritional anemia and acute blood loss or chronic blood loss, like in case of these worm infestations, ankylostoma or hookworm infestations. What they will do, there will be small occult chronic blood loss, or in case of GI, gastrointestinal ulcers, melena. So these are all the conditions of chronic blood loss. And hemolytic anemia, there are some hemolytic pathologies there also. And aplastic anemia is genesis defect in bone marrow. So we have red cell indices. You read in pathology, you know this, MCV, MCH and MCHC. MCV is, this is the average volume of RBC and the normal value is 80 to 96 femtoliters. And MCH is the average content of hemoglobin in average RBC and its normal value is 27 to 32. So MCHC, this is MCH by MCV. This is average concentration of hemoglobin per unit blood volume, and this normal value is 32 to 36%. When the patient comes to you with anemia, along with the peripheral smear, first of all you have to know which type of anemia. So we will give some investigations. Along with peripheral smear, we will go for these red cell indices, MCV, MCH, and MCH. And normocytic means its size is 80 to 100 femtoliters. When, in which picture? Hemorrhagic anemia due to acute blood loss, or too early iron deficiency anemia, or anemia of some chronic disorders like renal diseases, liver diseases, or bone marrow suppression, chronic renal diseases, and endocrine dysfunction. These all come under normocytic picture. And also autoimmune hemolytic anemia, hereditary spherocytosis, paroxysmal PNH, paroxysmal nocturnal hemoglobinuria. And microcytic means less than the size of 80 femtoliter, and this is seen in case of our most common iron deficiency anemia, thalassemia, and also some cases of anemia of chronic disease. But normocytic picture will be more common in case of chronic diseases compared to microcytic. And sideroblastic anemia, copper deficiency, lead poisoning also. Lead poisoning is also important. So macrocytic anemia, we all know, most commonly seen in B12 deficiency and folate deficiency, folic acid deficiency. So we will give this folate supplementation also in first trimester, because to prevent this anemia, and also folic acid has the advantage of it prevents neural tube defects. So in diagram you can make out the first picture is normocytic, second one microcytic, hypochromic also you can see in the center, macrocytes seen in the third picture, the increase in the size and also chromacity. And what are the nutritional causes? The most common, 90% of the cases, it will be nutritional anemia, that to iron deficiency anemia. And iron deficiency anemia, in it 50% will be nutritional anemia, and most of the times it may exist even prior to the pregnancy, and pregnancy aggravates. So this will be an intergenerational cycle, like an adolescent group enter into reproductive age who is having lower iron stores, and she will become pregnant with anemia, and the baby who is next delivering is also having lower iron and hemoglobin levels. This will be uncorrected in infancy and childhood. Again, in adolescence, there will be lesser iron and hemoglobin, along with it menstrual loss, and she again enters into the reproductive age group. So this will be a vicious cycle most of the time in underdeveloped countries and developing countries who are having poor nutritional status. The state of anemia will continue even through generations. Now, what are the causes? First, poor intake. Poor, on an average, Indian diet should have not between 20 to 22 milligrams of iron. And one more cause is poor absorption. Even if we are taken, absorption is poor. Normal absorption is 3 to 5% is absorbed. In pregnancy, minimum of 4 to 6 milligram should be absorbed to prevent anemia. So in pregnancy, there will be extra demand also. So what is that extra demand? 300 milligram for fetus, 50 milligram for placenta, 400 to 500 for increased red cell mass, 250 for the one lost during delivery, and 220 basal losses. So an extra of 800 to 1000 milligram extra is needed in pregnancy. And this is called a state of negative iron balance. And the extra loss during delivery is 150 to 200 mg, and lactation also she need iron supplementation because it requires extra 150 to 200 milligrams. And trimester wise, iron requirement per day is first trimester 0.8 milligram per day, because second trimester is where this physiological anemia will be going on. So in first trimester she will be having nausea, vomiting. This oral iron have extra these metallic taste and nausea, vomiting, gastritis, etc. Once her nausea, vomiting settles down, we will start iron supplementation, calcium supplementation. So second trimester, the requirement is 4 to 5 milligram per day, and third trimester 6 milligram per day. And also continuous blood loss. So lesser amount of continuous blood loss, like in case of bleeding piles or dysentery or our worm infestation, we all know ankylostoma duodenal, Nicotiana americanus, like 0.2 ml per day, 0.3 ml per day. So amount of blood loss will be there in worm infestations. And factors contributing to anemia, along with these loss or poor absorption or poor intake, what are the other contributing factors? Parity, multigravida. When she's having repeated childbirths, she will be becoming anemic and further anemic, and less interval, less spacing between the pregnancies. So there won't be enough time for her rejuvenation of her iron stores, and everything will be depleted with two closer pregnancies and multiple pregnancies. Multiple pregnancy obviously will require extra demand, and history of chronic illness, repeated urinary tract infection, worm infestation, history of excessive blood loss. Menorrhagia is excessive blood loss during menstrual cycle. So all this require extra, this is extra loss. So when iron is absorbed in the intestine, dietary iron content 10 to 20 mg iron, it is absorbed. The absorption form is ferrous form, and it is transported, gone into the ferret. Ferret is a storage form, and it can be utilized along with hemoglobin, myoglobin, and other enzymes, and stored in the form of ferric iron storage in the reticular endothelial cells. Next, iron loss will be from urine, sweat, and feces, and desquamation of intestinal epithelia, and menstruation in females. But there is no physiological excretion like in case of kidneys, like other forms of excretion. In iron, the most form will be desquamation, urine and sweat, menstruation in women. So she's anemic. What are the clinical features? Mild will have very few symptoms, and most of the time there will be compensation and they will accommodate well. They will be asymptomatic. Mild anemia most of the times. If it is severe anemia, they will have lethargia, shortness of breath, palpitations. If it is very severe anemia, she will start developing features of cardiac failure, means pedal edema, all these failure symptoms. And on examination, she will be pale. Pedal edema will be present. Still anemic, further anemic, facial edema will be present, and there will be increase in the placental size in some cases. And how can you detect this pallor? Where you will check for anemia? When you examine any antenatal case, we will see nail beds, lower palpebral conjunctiva, face, palm, hand. So, and the mucous membrane of mouth. You will ask her to show her tongue or lower palpebral conjunctiva or nail bed. So, to detect whether there are any, whether she's pale or not. And angular stomatitis or red glazed tongue, nails will become brittle, striae will be lost, and loss of their luster. So this is spooning of nail in very severe cases, you call it as koilonychia. This is very severe cases, some chronic cases. So you came to know she's anemic on your examination. What are all the investigations you want? First and foremost, hemoglobin estimation and blood grouping and RH typing, because she may require blood transfusion if she is severely anemic. Peripheral blood smear, because to see which type of anemia, RBC indices, and stool examination for this ankylostoma duodenal oval, serum ferritin, total iron binding capacity. These two are for iron deficiency anemia to rule out. Urine analysis for chronic urinary infections, blood urea and creatinine to renal things, liver function tests, and also serum protein. So these are the investigations we want to know which type of anemia and how we have to proceed for treatment. So first and foremost for any disease is prevention. How can we prevent? We can counsel to avoid frequent childbirths. So adequate and proper spacing, all the methods of contraception for temporary spacing. This helps in rejuvenation of the stores. Next, nutritional anemia prophylaxis program. So 100 mg of elemental iron and 0.5 mg of folic acid at least for 100 days starting from the second trimester is given to all pregnant women for prevention of anemia. And 12 by 12 initiative, this is achieved of 12 gram per by the age of 12 to 2012. Some scheme was done, but it's already 2020. I don't know whether it's achieved or not. Definitely it's not achieved. And weekly iron folic acid supplementation program. This is adults and boys and girls. They will get a tablet of iron folate every Thursday. So this is also one program. And supplementary iron therapy. Even with a well-balanced diet, supplementary iron should be given to the patient who, whenever she becomes free of nausea, because once her first trimester morning sickness and all settles down, she has to start iron. Only dietary supplementation is not enough in pregnancy. And daily administration of 100 mg of elemental iron and with 1 mg of folic acid is effective for prophylaxis. So dietary prescription. Along with this, you have to counsel her iron-rich diet. So how will you? Any pregnant lady visits to you, you ask her to take a balanced diet, rich in protein-rich diet, iron-rich diet. Okay, and it should be within the reach of the patient. If you tell too much costly diet, every patient might not be affordable. So it should be within the reach of the patient and easily digestible also. And previously they used to cook in iron utensils, but no, now not used. So iron utensils, if used, we advise them to not discard the water after cooking. And foods rich in iron are liver, meat, egg, green leafy vegetable, green peas, figs, bean, whole meat, jaggery. So these are all the diet rich in iron. We counsel them. And government in the schemes also they provide this called chicky. Chicky means groundnut and jaggery and liver. These are the rich sources in iron. And ragi also. So what is curative therapy? Specific therapy, the main principle is to raise her hemoglobin level and thereafter attempt to restore the iron. It will improve the stores also. So the choice of therapy depends on how severe the anemia is, whether it is mild, severe, moderate or very severe, and the duration of pregnancy. Her gestational age, if she is too close to delivery, then you cannot start on oral iron or you cannot start on dietary things. So you have to improve her hemoglobin faster so that she has to combat the blood loss of iron, delivery, lactation, postpartum. So you must be quicker and you have to choose like blood transfusions if she's too close to delivery. If you have time, you can go for oral or parenteral things. And if there are any associated complications, then also your treatment plan varies. So iron therapy, we have the two basic forms, oral therapy and parenteral therapy. Oral therapy is best absorbed in, iron is best absorbed in ferrous form, we all know. And the available oral formulations are ferrous sulfate, ferrous fumarate, ferrous gluconate. Most widely used is ferrous sulfate. So ferrous tablet 325 mg, which contains 60 milligram of elemental iron, trace of copper and manganese. This is the most commonly prescribed. The initial dose is one tablet to be given thrice daily, 30 minutes before meal. But when clinically, when we start iron prescription to a patient, initially we will give only once a day because iron has lots of gastrointestinal side effects. So after you ask her to take only once a day before the meal, up to bedtime, for 1 week. If she's tolerating well, then you can make it twice a day based on her need. Otherwise, only prophylaxis, routine antenatal, not any anemic means once a day is enough. If larger dose is required, you can go even up to maximum 6 tablets per day, but this is not practically possible because 6 tablets per day, the patient will be having a lot of side effects. If the patient is not tolerating, you can reduce the dose 200 mg twice a day or switch to ferrous gluconate. So one form of iron, if she is not accepting, there are a lot of iron formulations. We can switch to some other form of iron formulation and see which drug is suitable to this patient. And the treatment should be continued till her blood picture becomes normal, and then maintenance dose for at least 100 days following delivery to replenish the iron stores. This is about oral iron therapy. What are the drawbacks of oral therapy? The most important and most common patients frequently complain about intolerance. They have higher epigastric pain, nausea, vomiting, diarrhea, constipation. Iron is associated, pregnancy is associated with constipation because of the progesterone. It's a relaxing hormone. This iron adds on. Most of the patients complain of constipation and maybe related to increased dose of iron. If you start increasing the dose of oral iron, these side effects also will increase. To avoid intolerance, preferably with a small dose. So start one tablet a day, and if required and if she's tolerating well, you can go up to maximum 3 tablets per day. And if such a procedure fails to stop the symptoms, switch on to alternate preparation of iron. This is about intolerance and unpredictable absorption rate. So if even she taking the iron tablets, there are a lot of things which enhance and which decrease the absorption of iron. These antacids, oxalates, phosphates, tannates, they reduce the absorption of iron. But this ascorbic acid, like vitamin C, citrus fruits, lactate, they increase the absorption of iron. So you have to counsel her regarding dietary things also. And iron and calcium tablets both should not be taken at the same time also. One affects others absorption. Okay. So afternoon if she takes calcium, at the night she has to take iron. And with the therapeutic dose, serum iron may be restored, but difficult in replenishing the stores. So response to the therapy, she is using the drug, she is telling you, I'm using the drugs, and how can you say she's responding to therapy? And because of the side effects, most of the times patient won't take the medication, but tell us that I'm taking medication. So how, first question when a patient on iron comes to you is you ask about the color of stool. When the patient is on iron, color of her stool will be black color. If she's telling it's a normal in color, so the patient is not reliable, she's not taking the medication properly. So if she is tolerating well and she is responding well, means how can you say the first and foremost is sense of well-being. The patient herself after 1 week of starting therapy will feel like sense of first symptom to regain also will be this sense of well-being only, and there will be increase in appetite, and the general look of the patient will be improved, and hematologically there will be increase in Hb, hematocrit will come to normal value, and the reticulocytosis also starts within 7 to 10 days. And the rate of improvement, so oral or parenteral, it takes 3 weeks for the improvement. So that's why if the delivery is too close, you cannot start on this oral or parenteral because it itself takes 3 weeks for improvement. So that's why we go for blood transfusion when she is too near term. And after a lapse of few days, the hemoglobin concentration is expected to rise 0.7 milligram per deciliter per week. and no clinical or hematological improvement after 3 to 4 weeks, you have to reevaluate all the parameters and check the type of anemia. Means the patient is not responding to any iron. You have to search for other diagnosis other than this iron deficiency anemia. And parenteral therapy. If the patient is having a lot of side effects, gastrointestinal side effects, intolerant, and non-compliant, patient is not cooperative, then you can go with this parenteral therapy. We have two routes, intravenous route and intramuscular route. Intramuscular is not practiced now. IV we are giving. So intravenous dose also you can give repeated injections or a total dose infusion. So indications of parenteral therapy, if there are contraindication to oral therapy and the patient is not cooperative, and cases which are first time seen closer to delivery, means 8 to 10 weeks only left for her delivery, then also because you don't have to check on oral therapy for 3 to 4 weeks, again check and again go for parenteral, so that much time is not available. You are only 8 to 10 weeks closer to delivery, then directly go to parenteral therapy. And an expected rise of hemoglobin again here is 0.7 to 1 gram per deciliter per week. Both oral and parenteral will be increasing in hemoglobin in similar rate. So IV route, the compounds used are iron sucrose, the most common we use now, iron ferric gluconate, sodium ferric gluconate, and iron dextran. Ferric sucrose, iron sucrose is safer than dextran in IV therapy, and other newer formulations like isomaltose, ferric carboxymaltose are also there. Fewer allergic effects, and they are a bit costly, but they have many advantages compared to basic iron sucrose. So sodium ferric gluconate, that is 12.5 mg per day, or iron sucrose 20 mg elemental iron per ml. Iron sucrose, how we give is, first of all you have to calculate the deficit. So how will you calculate? Its formula is 2.3 into weight into 14 minus actual hemoglobin plus 50% for the stores. That is for iron sucrose. Like iron dextran also we have a formula 0.3 into weight 100 minus hemoglobin mg elemental iron. So you calculate how much deficit is there. Iron sucrose you cannot give all the deficit once a day. You per day we can give only 200 mg. That too on not consequent days, on alternate days. If we give 200 mg today, suppose her deficit is 1000 mg. So we have to give 200 mg on 5 alternate days. If given today, next dose day after tomorrow. So leaving one day in between, you have to cover all the deficit, iron sucrose. And also they are associated with a lot of reactions. First you have to give test dose. If the patient is comfortable with it only, you can go for the complete. So complete infusion takes like 15 to 20 minutes. It should be finished within 15 to 20 minutes. And when you are going for iron sucrose infusion or blood transfusion, if the patient is already on oral iron, you ask her to stop that oral iron the day before. And what are the prerequisites? Correct diagnosis of true iron deficiency anemia. First, you have to give iron, means you have to be sure that her deficiency is iron. And adequate supervision and facilities for if these are associated with reactions. Anaphylactic reactions are there, means you have to be prepared with how to manage anaphylaxis. You all know it can be a milder form to a very severe form. So you must be having a setup to deal with all those complications. Advantages: it eliminates repeated and painful IM injections. IM intramuscular injections are very painful, but IV not that painful. So decrease the repeated painful injections, and you can discharge the patient earlier, and it is less costly compared to repeated IM injections. Limitations are it is again not suitable if only 4 weeks are left for the delivery. Mostly suitable between 30 to 36 weeks of gestation. And the previous history of any allergic reaction to this parenteral therapy is there. Now again you should not attempt, because anaphylaxis, that to antenatal women, is difficult to manage. Intramuscular therapy nowadays not used. The used preparations are iron sucrose, dextran, interferon, jectofer. So these were used previously. Next thing is blood transfusion. So what are the indications of blood transfusion? Anemia due to acute blood loss. When she's bleeding acutely, antepartum hemorrhage or postpartum hemorrhage, immediately what can we do? Blood transfusion. And patient with severe anemia in later months, like after 36 weeks, after 37 weeks of gestation, she's having severe anemia, you have to go for blood transfusion, because not only to correct the anemia, and also the patient should be fit and she has to withstand the strain of labor and the blood loss following delivery. And if it is refractory anemia, you tried oral therapy, you tried parenteral therapy, but not responding, refractory. If she is refractory, you have to recheck on your diagnosis. You have to go back and see whether she is really iron deficiency anemia or not. But meanwhile, to save the patient, you have to go for blood transfusion. And associated infections are there also, blood transfusion helps. And advantage of blood transfusion is it immediately increases the oxygen binding capacity and stimulates erythropoiesis, supplies natural constituents of blood like protein antibodies, and improvement is expected after 3 days. What are the precautions? Blood transfusion is again associated with reactions, anaphylaxis. So utmost precautions to minimize the reactions. And if the patient is very severely anemic, like HB around 4 or 5, you are giving blood transfusion, there is likely overload on the heart. So that's why when you are giving blood for this severely anemic cases, we will go for packed red blood cell transfusion compared to whole blood transfusion. So PRBC is a better option for these candidates, and you should start very slowly. The drip rate should be 10 drops per minute. Even you can start with 4 or 6 drops also, and you have to monitor her very strictly, very carefully. Observe the pulse rate, respiratory rate, and any basal crepitations you have to auscultate, because if she develops cardiac failure or pulmonary edema, there will be basal crepitations. So with utmost care you have to. Sometimes we will give even Lasix, means diuretics before that, to prevent her from going into failure. What are the drawbacks? If after 36 weeks you found a severely anemic patient and connected a blood transfusion, she may enter into labor. So premature labor may start because of reaction to this blood, or increase the chance of cardiac failure and pulmonary edema if there is overload. And the features of transfusion reaction. These reaction chances are always there for blood. You have to check for bag number, blood grouping, mismatched transfusion. So this reaction chance is very much there for blood transfusion and also iron sucrose. So what is exchange transfusion? Its indications are cardiac failure due to very severe anemia. She is already in failure. And cases of severe anemia, now immediately she requires a surgery. And severe anemia near term. So this method is well tolerated, and within half an hour the patient will show dramatic improvement, but not routinely practiced. The management during labor. She is already in labor. First stage. First stage is all the events before the delivery of baby. Means the cervical dilatation, descent of the baby. So you ask her to be comfortable. Patient should be in the bed and comfortable position. And also arrangements for oxygen inhalation to keep ready. So if she is going into failure, you need oxygen support, and also connecting oxygen decreases the risk of fetal hypoxia. So the baby will also get adequate. When you're dealing with severely anemic or cardiac patients, connecting oxygen is helpful both for mother and baby. And strict asepsis, because these anemic patients easily catch infections compared to good hemoglobin status. So strict asepsis to minimize the puerperal infections. And in second stage is delivery of baby. So here also again strict asepsis should be maintained, and prophylactically we will go for instrumental delivery. How the baby will be delivered, we ask the mother to bear down. So with each contraction, there will be extra overload on the heart. So when you are dealing with the severe anemic or cardiac patients, we will cut short the second stage of labor by instrumental delivery. We apply this venous vacuum or forceps and we deliver. So mother bearing effect will be shortened with the help of our intervention, vacuum or forceps, and easy delivery of the baby. Next, intravenous methergine, 0.2 milligram methergine also given. This is to prevent prevent PPH, but not practiced. Methergine is not given now. Previously used to given. And third stage is after delivery of baby, delivery of placenta and membrane. So significant amount of blood loss should be replenished. So immediately you have to be ready with the blood fresh that to packed cell. PRBC transfusion should be done, and Postpartum overload on the heart should be avoided. If you cannot push and push IV fluids, there will be overload. So minimize the input. Puerperium. After delivery, 42 days, you call it as puerperium. So prophylactic antibody should be given. Even in an otherwise normal case, iron therapy should be continued for 3 months post-delivery to replenish the stores and to meet the demands of lactation. The patient should be warned of danger of recurrence of anemia again in subsequent pregnancies. So what are the effects of anemia on pregnancy? If she is anemic during pregnancy, starting from the first trimester, there is increased risk of abortion, fetal malformations, abruptio placenta, and increased susceptibility to infections, increased risk of preterm labor, and increased risk of low birth weight baby. During labor, increased maternal exhaustion because they won't be fit like that of a normal mother. Anemic mother cannot withstand even the normal amount of blood loss. If her hemoglobin is 12 or 13, and if she bleeds like 1000 ml of blood during delivery, she can withstand. If the hemoglobin is only 8 or 7, even 500 ml of blood loss also, that patient won't be able to withstand. So anemic mother cannot withstand even a normal blood loss. So it won't look like pph, it won't look like excessive bleeding, but she's not able to withstand or hold even that small amount of blood loss. And cardiac failure, severe anemia, cardiac failure again may cause maternal mortality. During puerperium, puerperal sepsis may be aggravated. With this anemia, blood loss, puerperium, they are prone for even DVT, venous thrombosis, and pulmonary embolism also. And after delivery, there can be subinvolution of the uterus. The uterus after delivery has to come back to its normal size and position. There can be subinvolution due to infections. Infections also, these anemic patients cannot handle like that of a normal case and not easy to treat. And failure of lactation, they won't be able to feed the babies properly. And if any infection happens, or cesarean section, there will be poor wound healing. So wound healing won't be proper, and again resuturing, wound infections, etc. And if the anemia is from acute blood loss, immediately. So in early pregnancy, what are the conditions? Due to abortion. After abortion, if she's bleeding very much, or ectopic pregnancy, ruptured ectopic, she's bleeding inside the abdomen, hydrotiform mole, or postpartum means anemia from obstetrical hemorrhage. Blood transfusion, it is not indicated if the HP is 7 and the patient is hemodynamically stable. So compensatory and able to ambulate without adverse symptoms, not septic, and oral therapy can be given at least for 3 months. These kind of cases. And if the anemia is associated with chronic diseases like chronic renal insufficiency, chemotherapy, like cancer patients, HIV patients, chronic inflammation, and most common thing is chronic renal insufficiency only. Patients who are on dialysis, chronic renal disorders. So you have to treat on underlying conditions. Autoimmune hemolysis, both direct and indirect home test will be positive. Antibodies will be positive. Here again, the treatment will be steroids and monoclonal antibodies, prednisolone and rituximab. This is rare. That in pregnancy, we will deal with iron deficiency anemia only. So a mild microangiopathic hemolytic picture will be seen with thrombocytopenia in severe preeclampsia and eclampsia cases, means hypertensive cases. Acute fatty liver of pregnancy may be associated with moderate to severe hemolytic anemia. Okay. Students, any doubts? Now I think you have a picture about anemia. Don't break too much because you will read further about anemia in upper classes. You are only 5th semester. Now I think you have just a basic idea what is anemia and its importance during pregnancy, how we are going to deal with it. Okay. Just a second, I'll confirm the attendance.